It
Me?
should
All right.
show we are streaming.
Can you send me the link or wherever you need to click on it?
Yeah, give me 1 sec.
Davini, are you doing the introductions?
Yes, I
Yeah.
am. We got a sort of little bio for you from Sarika. Is there anything in particular you want me to say, or do you want to introduce yourself so people prefer that?
Not especially. I'm fine with whatever. I can do my own little intro if you want. It's just there's not much to it. I mean,
You're F1 at Barnet, right? Okay, yeah. I'll just say that and then I'll let you take over.
Okay,
You
cool.
can say what you want to say.
Thanks. I mean, I'm sure you cover most of it anyway.
All right, checking the live stream now.
Fantastic.
One person watching me.
Right. So if I press slideshow now, can you guys see all of this?
Yeah, someone highlight you.
Okay, I can see myself. I can hear myself.
Hang on. So I do this, and then play from start. Yeah.
Yeah, perfect. We can see that.
That's all good. Okay, good. All right, sweet. And then if I switch to my Mentor, can you guys see that or not?
No, you can't see anything.
No. Okay, perfect. Good. Okay. So I just start the Mentimeter thing as well there.
Yeah, cool. And we can
So Viren, I can see what you did there, by the way.
The YouTube's all right, yeah.
Yeah, it's a bit delayed, but does the job.
So I can't see the chat. So if there's something, I'll just say like questions. We'll address questions after sort of maybe halfway through. We'll go through questions if someone put something in the chat. But
yeah,
if it's urgent, like I'm too quiet or something or other, then can you just let me know because I can't see it where I am.
Yeah.
Fine. Can we have like maybe two of us just like taking questions just in case people wouldn't have any? Just direct it to us. Maharsh and Trivini both staying on here, aren't you?
Yeah.
Yeah. Okay.
Yeah.
Maybe half it between you two. Like one person takes one half, one takes the other half.
Yeah.
Yeah, I'm happy.
Yeah. So I don't want. I know you guys are probably learning from this too, so I don't want to disrupt that. So yeah. Okay. Cool. Bloody hell! All right. This is good.
People.
Yeah, I'll probably dip on this account. So if you need any recording or if you notice anything's wrong, just message the recorder account.
I got my phone on.
Okay,
Call me
cool.
if
Is recording the session going to be an
I'm not
issue with the
recording
whole live?
Zoom. It's just live on YouTube.
Okay, so we should still be able to record it.
Yeah,
fine.
it's just an overflow worst case, so just pop it into chat.
Will do. Thanks.
And wait, before you leave, if it does go overflow, we'll text you. Just put it straight into the Facebook group. We'll put the message into Trivini will put a message into the whole chat. So anyone has it, we'll send them that link and they can just go on it basically.
Yeah.
Okay. Cool. All right. Mad. All right. Fab. Let's see how much we go. We've got 77 in the waiting room. 8. Ooh. All right. We'll leave it till 5. We'll let them in. And then 2 minutes. We'll just keep them waiting around. If at that moment, I will turn my camera off as well as everyone else. Trivini can keep yours on. Video introducing. And then just be like we'll start at 5 past exactly, and then start 5 past exactly, no matter how many people are on it. Yeah.
Sounds good. Wait, so sorry, when are we letting people in?
Just let him on the dot, really.
On the dot? Yeah.
Yeah.
Cool.
Yo, if we don't reach 300, then you need to stream it to YouTube or just.
Yeah, if we don't reach the numbers we need into 10 minutes or 5-10 minutes into the session, then just leave it. All right, cool. Are we all ready? All happy?
Yeah.
Yeah.
Right. Okay. So when you're ready, just let them in. I'll turn my camera off.
Mm-hmm.
Right.
This meeting is being recorded.
Hi everyone, thanks for joining us. We're just going to wait a few minutes so we can get a few more people in. We'll be starting at 5 past. Thank you for joining, and everyone please mute your mics and turn off your cameras. Thank you.
Don't recording.
So for those of you that have just come, just want to remind you, please keep your mics off, your cameras off, and we'll be starting in 3 minutes. Okay, so let's get started. Thank you everyone for joining us for our BIMA clinical crash course series. For those of you who haven't joined us before, so we're doing this crash course. We started with Gen Med, we're now moving on to specialties, and we're starting with peds, as you can tell. Dr. Sharma, if you wouldn't mind going to the next slide. Thanks so much. So this is just an introduction to the team. Got President, Almar, Sarika's academic lead, and myself and Maharsh are the clinical officers. So we're the ones that are kind of behind the logistics of the crash course. So like I mentioned, this is our specialties crash course. So we're starting off with 5 weeks of peds, 4 weeks of obs and gynae, and then 3 of psych. So we hope to see you all for the next week's sessions, and it's every Sunday around this time. And just before I introduce this session, I just want to say right at the end of the slides, there'll be a feedback form. And if you could please fill that out. Dr. Sharma has kindly given up his time to teach us. So great to get feedback. And if you put your email address at the end, we'll email you a copy of the slides. So just to intro Dr. Sharma. So Dr. Sharma is an F1 at Barnet. I'll let him explain his interest in peds, but thank you so much. And please go ahead.
Thank you. Hello, everyone. I didn't actually expect this many people. I also didn't realize Amar was president, so it's fair play to him. Basically, I'm Shiv. I'm an F1 at Barnet. I hope you can all hear me all right properly as well. I have an interest in pediatrics since sort of the middle of medical school. I did my BSc in pediatrics. I've done a little taste week in pediatrics. And I hope to go on to do pediatric training after F2. If I could just let you know that you can sign on to menti.com and then put that code in. I'm sure the Imperial lot will be very familiar with that. And now after years of putting troll messages on Mentimeter, I'm now on the other side of that, so I'm kind of scared. But let's see how it goes. So there should be a couple of questions as we go through. And we'll be able to see how you guys get on. So you can just do that on your phone or your computer. Right, so let's get started then. So here's what I'm roughly hoping to cover today. Obviously, I know you will all have a focus on your exams, and I'll try and give you things that are useful for exams and since there's a wide range of medical schools, I'm not going to be giving you, niche SBA knowledge that, generally is reserved for one medical school or another medical school, because that tends to vary and I don't want to waste your time. So I'm going to give you sort of two trains of thought. I'm going to give you things which every F1 should know, and I'm going to give you things which are very useful as a clinician as well. So things which, by the end of medical school, you should be grasping these concepts. And then also when you are assessing a child, what is actually clinically useful for those of you who, might need it. And you might think that, you're not going to do pediatrics, but actually if you have an A&E job, which many, almost all F2s will have an A&E job, you're going to be seeing pediatrics patients. If you're a GP, you're going to be seeing pediatrics patients. So actually the vast majority of you will be exposed to pediatrics patients at some point in your careers. So we'll look at the deteriorating child, which is slightly different to an adult, and we'll go through why and how to look out for things differently. We'll talk about assessing and managing deteriorating children. Fluid balance, I know, is a really tricky one, and I stressed about it a lot in 5th year. And I'll try and simplify that for you, because it's still quite tricky. DKA, anaphylaxis, seizures, these are kind of key emergencies to be able to manage. I'm not going to talk you through every detail of every guideline, because I don't think that's useful, and I'll explain why later. But you need to be able to grasp the basic concepts of management, the time scale of management, the order of prioritization as you manage these patients, especially in SBAs where you have 3 options, which are all good options, but one will be the most urgent for that particular emergency. And then we'll talk briefly about airway problems, which is something more prevalent in pediatrics than in adults, as far as exams go, especially. Right, so general principles of managing children. Arrests and emergencies in children, there's sort of a narrower range of common causes, and that is probably due to the fact that we're really good at preventative medicine in kids more than any other group. There are a narrow range of causes to know about, but they are just as important. And just because you won't get the spectrum doesn't mean you don't have to spend as much time sort of preparing and understanding them. And in fact, you're expected to know them in more depth than you would think, considering you're a medical school and you're not applying for pediatric training, especially that's what it was like at Imperial for sure. And I don't know what it's like everywhere else. It is hard to get clear history because you don't have a patient who's always verbal, and you don't have a patient who's always coherent enough and has the vocabulary to explain what's going on. You're not going to be asking, is it central crushing chest pain, or is it burning chest pain, and does it radiate to your back? Those things are much harder to ask in a pediatric population. It's hard to do invasive procedures and tests. You're not going to be able to get bloods as easily. You're not going to be doing CT scans head to toe in pediatrics patients. So generally, you have to rely more on your clinical acumen and clinical signs and symptoms, which for some people is quite an attractive thought, because there's less sort of fact-based and biochemical cutoff-based decision making. It's more clinical, and there is sort of more use of a clinician in those situations. Finally, children compensate really well, and it took a long time to understand this until I saw some really sick kids in pediatric HDU and things like that on 5th year placements. Kids can look fine and they can be really unwell, and then when they drop off really quickly. So obviously in an exam it's not going to be like that. They will telegraph it for you because you can't see the child on an exam paper, but you need to be able to understand that children will auto-regulate, and we'll explain some mechanisms later where they will actually hold up their numbers and look better than they actually are. And you need to be able to look for signs which are harder to look for than an adult. An adult who's unwell will look it, right? But a younger child can look just fine even though they have fulminant sepsis. And that's why it's super important. These emergencies come about really quickly and they sneak up on you. And the other thing is that normal ranges for OBS change with age. I think that's really tricky. I don't think you should bother sitting there learning them all. I think it's not a good use of your time. Have a rough idea